All right, we're going to go ahead and introduce the first speaker. It is going to be Dr. Ragheb, Director of Pediatric Neurosurgery and Chief of Surgery at Nicklaus Children's Hospital in Florida. He's going to be covering current state of focused ultrasound with a contrast to laser ablation. Thank you very much, Dr. Ragheb, for being here.
Thanks, Kathy. Thank you, Lisa, and the organizers, and thank you all for being here. Good morning or good afternoon or where you may happen to be. Let me see if I can figure out how to share my screen. Can you all see that?
Yes, sir.
Great.
You're good to go.
So thank you again for the opportunity. It's my pleasure to be here again. It's obviously not the same as being with you in person, but at least we don't have to wear masks. So I'm going to put mine down. What I'd like to do today is tell you a bit about our preliminary experience with focused ultrasound in the treatment of hypothalamic hamartomas in children. And by way of disclosure, I want to make sure everybody understands that this is a research study. It's described as a feasibility and safety study. It's sponsored by the Focused Ultrasound Foundation, which is based in Virginia. I don't have a financial stake in the device, and I don't get paid by them. But this is not an FDA-approved use for focused ultrasound. It is what's technically considered an off-label use. But I will talk to you about our research experience so far and try to put this in context and to compare it with the existing treatments, which is why it makes sense for us as a community to invest in new technologies like this. So let's begin by asking the question, what is optimal management for hypothalamic hamartoma? And I honestly, every time I have a conversation like this, it really depends on who we're asking, right? It's in the eye of the beholder. It's our perspective. And there, of course, there's the doctor, there's the medical professionals, there are the patients and the families. And I think we all have slightly different perspectives on this, all of which have value. But I think we can all agree that what we really want to do is to control the symptoms and signs that brought the HH to our attention, that we want to do that with as little risk and morbidity as possible, and causing the least amount of harm and providing the greatest amount of benefit. So if we begin with that principle that we need to think together how to minimize the harm and maximize the response, it'll lead us honestly to a discussion about how do we get here and what are we going to compare the new treatments to. You know, I've been in neurosurgery for a little while now. I think that's probably the tip off is my gray hair. And I've seen the progression of the surgical treatments for hypothalamic hamartoma over the years. And I've been fortunate to be part of many of those treatments and can speak to them directly. You know, the surgical treatment for hypothalamic hamartoma really dates back to the middle of the last century, as does our children's hospital here in Miami. And this is what it looked like when it was a tuberculosis sanitarium on the edge of the Everglades in the 1950s. And it's evolved as our program has evolved. And one of the things that's unique about our program in Miami is that it's known for the surgical treatment of epilepsy in children. And of course, one of the common types of epilepsy that doesn't respond to medical treatment is gelastic epilepsy caused by hypothalamic hamartomas. So over the years, our program has evolved into this new state-of-the-art facility. And along with it, our program has grown and we've seen dramatic changes in the kind of tools we use to treat children. It's evolved from the early days where we recorded on VHS tape and put in large grids and drew cartoons to be able to identify where the electrodes were, to the modern three-dimensional reconstructions created based on CT and MR imaging that's fused together. And a great deal of this was all started by my senior partner, Dr. Glenn Morrison, who's still active in the program, but now clinically retired. Over the years, we've taken care of over 1,300 children who've had surgical procedures here at what used to be Miami Children's and is now Nicklaus Children's Hospital. The program has grown over the years. The types of procedures we've done have evolved, and our tools have evolved over time. And as I mentioned, we've done the early large operations where we put electrodes in, but we've also embraced the less invasive approaches, including things like neuromodulation, both peripheral and central neuromodulation, and other ways of getting information from deep in the brain using tiny electrodes that are that pass through the skull. So all that experience has sort of culminated in this talk and how do we optimize management for hypothalamic hamartoma. I was asked to talk specifically about laser ablation, and we're an early adopter of laser interstitial therapy, or the type we use is made by Medtronic called Visualase. We started doing the procedure in May of 2011. I did the first procedure then. And over the years, we've treated just over 70 patients now. This was 70 as of December 2019. The vast majority of those patients have had epilepsy as the reason for their treatment. And they've included things like malformations of cortical development or cortical dysplasia, hamartomas like hypothalamic hamartomas, and subependymal hamartomas, a different type of neuronal hamartoma that causes epilepsy. And some have had typical temporal lobe epilepsy, but the vast majority of them have been extratemporal, which is the most common type in children, in places like the hypothalamus or in the subventricular zone or elsewhere in the cortex. And here's just an example of one of our early hypothalamic hamartoma patients with the laser device in place at the time of treatment, and then 3 years afterwards with a little hole here in the hamartoma and a functional disconnection. And this child fortunately remains seizure-free now 7 years later. We published our early experience in 2015 with 1 year follow-up and showed promising results, the focus of which was really on treating all types of epilepsy, including hypothalamic hamartoma. But as is true of any new technique that comes along, as we push the limits of that technique, we begin to learn its limitations. And here's an example of a patient referred to me recently from outside the United States. This child has a large hypothalamic hamartoma that you can see here on the sagittal image. It has a hole in it from the efforts of the surgeons who've been managing that child. This child has had 5 laser interstitial ablation treatments in 2 sessions, as well as a endoscopic resection, and she continues to have gelastic epilepsy in spite of that treatment. So it just shows the limit and that we've gone to try to push a technology to maximize symptom control, not always with success. It leaves us looking for alternatives. And the alternative I'm going to talk about today is something called focused ultrasound. Now, focused ultrasound sounds kind of esoteric, but it's really been around since the middle of the last century. The concept of using sound waves to create heat and passing it through tissue began in the 1940s and was used to treat lesions inside the brain as early as the 1950s. But of course, to do that, you had to open the skull and place the sound transducer directly on it. The limits at that time were our ability to see what we were treating and to monitor the treatment. And this lovely review of focused ultrasound therapy that appeared in Nature Review this January by the group in Toronto, and Dr. Lippman in particular, sort of highlights the number of publications and reflected in the interest in science back in the 1990s. And here's what you see with publications in the 2000s, in 2010, in 2015, and now currently. So there's a tremendous amount of interest as the adaptations and the technology have evolved. Focused ultrasound focuses ultrasound waves either through an opening in the skull from an implanted transducer, focused from a small external transducer, or from a large hemispheric transducer, the goal of which is to focus those sound waves at a tiny point and to be able to deliver energy translated into heat that can then be monitored in the MRI machine. The interest has grown globally. And this is just, again, from that Nature Review showing all of the centers across the world at the end of last year, and all of the different areas of interest, including Parkinson's disease, brain tumors, tremor, epilepsy, behavioral disorders, et cetera, et cetera. So there's a tremendous interest both in the medical literature in the United States, Canada, and Europe, and globally on focused ultrasound. I think a great deal of that's been driven by the development of systems that are now commercially available. And when you put a system like this in the hands of doctors, we look for ways to use it, recognizing the gaps in our available treatments and where it can help our patients. So the particular device that we have in Miami is made by a company called Insightec. The company was established in Israel in 1999. A group of engineers got together to try to work on this idea of focusing ultrasound through the skull effectively and being able to image the heat generated in that treatment in real time using an MRI machine. So what you see in the picture here is the MRI machine and the ultrasound transducer. The device was took, nearly 15 years to become ultimately approved for the use of essential tremor in adults. And we'll talk about that here in a moment. So this is the unit we have here in Miami. It's mated to a 3 Tesla GE MRI machine, and the regular MRI table, it looks like a submarine for our children's sake, gets replaced by the treatment table, which has the ultrasound transducer. And then the whole system goes into the MRI machine to be able to take pictures of the brain as the ultrasound waves are passed through the skull and into the brain. The company has grown dramatically, and therefore the interest has grown tremendously. And this is a slide from their website, which shows all of the centers as of the spring of 2021 that have this technology in place. All of these centers are doing a combination of adult treatments for essential tremor, as well as research using other types of focused ultrasound therapy. I think we're the only center that is not treating adults with essential tremor. As is true of anything, it's attracted investors, and which has driven its growth. An essential step in all of this is approval by governments, and of course, it's been approved by the English health system, the Japanese health system, and I believe recently also by the Australian health system for the treatment of essential tremor. And along with their governmental approval then becomes insurance reimbursement, and the technology grows. Focused ultrasound therapy delivers heat through the skin and skull into the brain, and its effect is described as being able to create a lesion by creating heat, as you see here on the left, and we're going to talk primarily about this. That energy can be adjusted to do other things too, and one of the things that seems very interesting and unique is this idea of neuromodulation. And I'll refer to that at the end because I think that has very exciting potential, particularly for how we think about treating hypothalamic hamartoma and minimizing the trauma of our treatment. So, as I said, the treatment and for essential tremor has changed dramatically with the FDA approval of focused ultrasound therapy. And this is an example of a screenshot from the treatment unit of an adult having a thalamotomy, a temperature-generated lesion in a portion of the thalamus. That temperature is monitored during the treatment with the patient awake, and the tremor can be monitored as the treatment progresses. The treatment for essential tremor is now so refined that it takes about an hour and a half to do. And it's done as an outpatient. The patient's awake throughout the treatment, obviously, because they use it to monitor the tremor. And that culminated in this seminal article published in the New England Journal of Medicine in 2016. One of the fortuitous things about this is that our fellow in 2016 was Dr. Travis Tierney. He's a fully trained functional neurosurgeon who spent a year with us to learn pediatric neurosurgery and then stayed on to help us get our focused ultrasound program up and off the ground, along with Dr. Ian Miller, one of our brilliant child neurologists. So how does this thing work? Well, the way it works is that it uses a transducer system that has 1,000 plus piezoelectric transducers. They convert electrical energy to sound waves. They're situated in a dome, and that dome is built into this helmet. The dome focuses all of the energy on a single point. And that single point has a very sharp peak with a very brisk drop off. And when you use that to treat tissue in the brain, what you see is a very precise line where the injury area stops and the healthy tissue starts. And this is a 1/10 of a millimeter gap between where the treatment occurred and there's tissue destruction and where the healthy tissue is preserved. So very accurate, but it requires a great deal of effort to maintain that accuracy. We'll talk about that in a bit. Those sound waves are different from the kind of sound waves that you might have if you're treating a problem in the abdomen. Focused ultrasound therapy has been used for quite some time now to treat things in the abdomen. Examples are tumors in the uterus and in the kidney and or liver. That those use parabolic or fixed focal point ultrasound transducers. The ones for transcranial use are generated by radio frequency and can actually be focused electronically, which gives us a degree of flexibility. It's where all these sound waves cross that the energy is delivered and the magic happens, just like in Star Wars. By way of review, we know that as the energy increases in tissue, it has an effect on the function of neurons. And research in animal models shows us that as temperature goes up, the neurons stop working, and then the proteins begin to fall apart, and then the tissue starts to clump together, and then at a certain temperature, we know the tissue dies because all of the cellular machinery becomes gummed together and stops working. We want to avoid temperatures in this range that might potentially cause boiling, because when bubbles form, that can create what's called cavitation, and that can have catastrophic consequences. It's trapped inside a space, like inside the body. There are some technical limitations on where the energy can be delivered, and suffice to say that because of the way the transducer system works, the energy has to be focused in this red area here because of the kind of sound energy being delivered. And that's actually fortuitous because hypothalamic hamartomas are right here, and they are right within the treatment window. So as we began to develop a protocol to use this device that we were fortunate to acquire in 2016, as a children's hospital that sees lots of patients with epilepsy, we knew we wanted to treat patients with epilepsy, but had to find something for which there were no other treatments available or where treatments were insufficient. So those were primarily benign types of tumors that had very few blood vessels, because prior studies in humans had shown that if you treat a malignant tumor with lots of blood vessels with sound energy, those blood vessels can break, and that can cause catastrophic bleeding. So we, in an effort to make this as safe as possible, picked benign tumors that were within the treatment volume and fit our patient demographic. So we take care of children, and in the state of Florida, you're a child until you reach your 22nd birthday. So I can sneak you into the children's hospital until you turn 22. The FDA, the Food and Drug Administration here in the United States, had to approve this study under what's called an investigational device exemption. So this device is a research tool that we have access to use for children. And in order to do it safely, we wanted to start with young people who were as close to adults as possible. The first group would be 18 to 22. Once we succeeded in treating those patients, we were allowed to move down to the group between 12 and 18, and then eventually down to age 8. At each phase, we had to stop the study and prove that we were still doing it safely. Ideally, they were small lesions that needed treatment, obviously, and the fact that you've had an operation in the past does not prevent you from being a candidate for focused ultrasound therapy. So this is what's called a single-arm, non-randomized safety and feasibility study. I'm going to stress that. This study is about, can we do it safely, and is it possible to be able to deliver treatment to these regions of the brain? The study opened technically in January of 2017, and we treated our first patient about a month later. And I check periodically. There are now 11 studies on the clinicaltrials.gov website that are focused ultrasound trials for brain tumors. There's only one other pediatric study, and that's not an ablation study. Ours is still the only ablation study that's registered under the clinicaltrials.gov site. So who's a candidate? Well, the candidates are people under the age of 22 that have a benign central lesion that need to be treated. What would be an exclusion Obviously, if you're on medications that make bleeding a possibility, if your tumor is large, if you have a stimulator or some other metallic device that prevents us from treating you safely, those people are not candidates. Shunt examples might be programmable shunt systems, a vagal nerve stimulator, a neuropace or responsive neurostimulator, things of those nature. As I mentioned, with every research study, the goal, of course, has to be clear. And I want to make sure everybody understands that this is a study that is designed to prove safety and feasibility. We'll talk about results, but this is a safety study first. First, we have to prove it's safe, and then ultimately, I hope we can get our colleagues across the country and globally to help us prove that it's effective. In addition to safety, we want to make sure that there are no neurological, endocrine, or radiologic complications that we can see. We want to make sure that the child's overall physical and emotional health is preserved, and all of these are followed within the protocol and monitored carefully for the first year. So what would be the ideal treatment? And because we've treated many patients over the years, and not all of those treatments for children with epilepsy have been successful, I showed you an example of a hypothalamic hamartoma sent to me by another center. And we looked through the patients we've treated in the past for which we realized that we could do better. And the conclusion was that hypothalamic hamartoma was probably the ideal substrate that would respond to focused ultrasound for which our other treatments were unsatisfactory. And I think this audience certainly knows and understands what a hamartoma is, but they are essentially benign tumors, meaning they're a mass that don't grow, and they're thought to be congenital, being present at birth. They cause trouble because they can cause gelastic epilepsy, those odd laughing seizures. They can cause precocious puberty and behavioral disorders, as well as a litany of other things that I'm sure the audience is well aware of. So why is this area lacking in adequate treatments? I think that's important because if we're going to expose someone to an experimental therapy, we need to be able to justify that by saying that this approach makes sense because it's less risk. And what makes this less risky are all of the important structures that are around the hypothalamus. And I remember being at the meeting in person in Washington, DC a couple of years ago, and there was an elegant talk given by a neuroanatomist of all the important structures packed into the hypothalamus. And I won't bore you with all the nerdy neurosurgeon details, but if this is a slide of an anatomic specimen through the hypothalamus, as though you were looking at the person from the front, these are all the nuclei or areas of packed neuronal function that cluster together and have discrete, at least thought to be discrete functional components that are within the region around the third ventricle and in the hypothalamus. And those are between the third ventricle and the optic tract. And of course, as I said, why is this important? Well, what do we use as to compare focused ultrasound therapy against so that we can rationalize its use on an experimental basis? What makes the existing treatments unsatisfactory? So as we were developing the focused ultrasound protocol, what's considered the first line of therapy had evolved to the point that laser ablation was considered first line or best practice therapy for many children with hypothalamic hamartoma. And there's been a great deal written about that by many groups. This is from the Barrow group from a few years ago. Just for background, for those who may not be familiar with what's called laser interstitial ablation, one of the brand names is Visualase. That's the system we have. That's the oldest existing commercially available system. There's also a Canadian system as well that's slightly different, but the principles are the same. These laser interstitial thermal ablation systems rely on a laser fiber that is placed within a metallic bolt that's fixed to the skull. That fiber then passes through the brain and into the target. And here's an example of a patient of mine having a temporal lobe lesion ablated. You see here the device fixed to the skull just above the child's ear. This is what the device looks like. It's the cooling catheter that's on the outside. It's is about 1.5 millimeters in diameter. It has an opening at the end that creates heat. It creates heat by shining the laser light to it. It hits the end of the catheter and then it diffuses into tissue. that heat that's generated is monitored in, quote, real time by MR imaging. In reality, those images are refreshed every 6 seconds, and we measure temperature based on the motion of water molecules on the MRI scan. So this is what was considered the standard of care and for children with hypothalamic hamartoma. But I've already shown you that it lacks, it leaves many things lacking. And I think one of the most striking things is what happens when you pass a 3.2 millimeter catheter represented to scale through the hypothalamus to this cartoon drawing I've made of a hypothalamic hamartoma. Here's the hypothalamic hamartoma hanging off the end of the hypothalamus. This is what the size of that laser catheter would be like, going through all of these essential clusters of neurons as it goes into the hypothalamus and then into the hamartoma to create heat and destroy the connection between the hamartoma. I think that's where the morbidity comes from when we treat hypothalamic hamartoma with a laser catheter. It's the trauma of passing it through the hypothalamus, as well as the heat that spreads into the hypothalamus in ways that we can't control. So as I said, this is a safety and feasibility study. It involves using general anesthesia. Our patients are asleep, unlike the essential tremor patients. The treatments take a very long time because there are many, many individual tiny ablations necessary. A frame is fixed to the head after the patient is asleep. That frame is shown in the cartoon here. It's then fixed to the transducer dome, which has the 1,000 transducers that are all focused in the middle on the area of interest. In the gap between the transducer and the scalp is cooled water that has all of the air bubbles taken out of it so that it creates efficient transmission of sound through the water bath and through the scalp and into the brain. But that water is actually quite cold. It's at 20 degrees to 20 to 23 degrees centigrade, which is very chilly, which is why it's a good thing that people are asleep, because it becomes uncomfortable after a while. Initially, we use low energy sonications or sound treatments to make sure that our focal point is in the correct place. And then we increase the temperature by increasing the energy incrementally. And in 2017, we treated this young lady who was a patient of ours. She was treated by my partner, Dr. Sanjeev Bhatia. At the time, he tried interstitial laser ablation for this lesion, which you can see is in a sessile or broadly attached to the hypothalamus. It created a defect within the hypothalamus, but it did not stop her gelastic epilepsies. And unfortunately, it was associated with a significant deterioration in her behavior and marked hyperphagia, or this endless desire to eat. And she gained nearly 50 kilos between the initial treatment and this ultimate focused ultrasound treatment over the span of about 3 years. So she was our first patient. And this is, again, what the control monitor system looks like. It shows an individual sonication. It shows the temperature being monitored at its maximum and in its average. And there's a series of little dots that get created to try to separate this lesion from the normal brain. And this video, produced by the Focused Ultrasound Foundation, animates the process of the treatment. So this is actually that patient. This is the skull that modeled by the foundation. These are the sonications. These are all the transducers shown geometrically over the top of the head. These are the beams that are recreated, and a computer model can model the treatment. The red dots are heat being scattered through the skull. And then in real time, the treatments are delivered. It creates heat. We monitor the heat. And then once we reach the target temperature, the system moves the head a tiny bit with our help. And the next treatment ensues, and then the next, and then the next, and then the next. And I think this required 28 sonications in order to actually cover this little gap between the hamartoma and the hypothalamus. And at the end of this, we do a formal MRI scan. The pictures here are somewhat degraded because the MR transducer is well away from the head. The patient then is, as per protocol, goes from the MR unit to get to the ICU. She spent one night in the ICU. She was able to have supper that night. She had very little in the way of headache. It only required a bit of Tylenol. And that was really related not to the treatment, but to the way the head is held still in the MR scanner. She was sent home the second day, as per the protocol. And now it's been 3 years now since her treatment. She's had no seizures. She's still on her medication. And we learned a great deal from this, mostly about how to deliver energy and how quickly we can ramp up the sonications, because it took us 8 hours to do this first treatment, which was, of course, the longest of any of the treatments. Since that time, we've treated 4 other patients with hypothalamic hamartomas in our total of 5 patients that we've treated in the series. And this outlines those patients. And again, we are obligated to treat the first 3 between the ages of 22 and 18. And then we've treated 1 patient in the subsequent younger age group, and she was 15. Of note is that all of these first 3 patients had failed other treatments: endoscopic resection, laser ablation, and gamma knife, and all had seizures as well as the side effects from those treatments. The only patient that did not have gelastic epilepsy was our 4th patient, and I'll talk specifically about her. These are just images of all of those patients prior to treatment, in the midst of the treatment, and then 3 months later. And what you see is the lesion with the effect of the heat, and then a little bit of a residual lesion in some patients. But in some patients, here's the lesion, here's the midst of treatment, and then not much left. So you don't see much of the lesion treated during the treatment 3 months later. And the results have been very gratifying, although this is not a study about the outcome, it's a safety study. All of the 4 patients we treated with hypothalamic hamartoma had no neurological, endocrine, or emotional or behavioral consequences from the treatment. All of them have been seizure-free or nearly seizure-free since the treatment. And the 4th patient, who was treated not for epilepsy, but for hypothalamic hyperphagia, has also had a very gratifying result. I'll highlight that patient because it's the most unusual of all of the treatments. And this was a young lady whose mother is a nutritionist. They're from England. They were referred to our center from their endocrinologist at Great Ormond Street in London, because this child, who presented with precocious puberty at age 3 that was controlled with medication, developed hypothalamic obesity. And in spite of her mother's best efforts to control her weight was rapidly rising. And as a teenager, that became a real significant problem for her. Because this had a very narrow connection to the hypothalamus, it was felt to be not a good candidate for laser ablation, and that the risks would be significant because this is a very small isthmus or neck that connects this relatively small lesion to the hypothalamus itself. And rightly so, her mother was concerned of the effects of this, particularly since one of the most common side effects from laser ablation is pathological hyperphagia after treatment. So that was not a good option. And they contacted our center, and we were able to treat this young lady in the fall of 2019. This is the hamartoma, the neck, treated with focused ultrasound. This is the area that was of central necrosis, and this is the heat generated across the neck of the lesion. And this is Madeline the day after the treatment with her new hairdo, because we have to shave the hair to do the procedure. This is one of the pin sites. This is the lesion 3 months later. And this is Madeline 6 months after treatment. At this point, she'd lost 13 kilograms. Her hair is growing back, and she had a completely different outlook on life. And both Madeline and her mother were very happy with the result. She's now almost 2 years after treatment. She's managed to keep that weight off in spite of being locked up in the house by COVID like the rest of us, and is doing very well. So not all of our treatments have been successful. This is an example of what we learned wasn't a success. This is not a hamartoma, but a subependymal giant cell astrocytoma. We learned a great deal, and I expect we'll continue to learn about focused ultrasound treatment. One of the things we've learned is that you don't have to create tissue destruction to be effective. So this is a list of all of the patients globally as of April of 2020 who have had focused ultrasound treatment for epilepsy or a subcortical lesion, like a hypothalamic hamartoma. 4 of these patients are our patients. And what's interesting to note is that not everybody has a complete lesion at the end, but yet they can have a satisfactory clinical result. And I suspect we're going to learn more about this as we recognize that the energy delivered by focused ultrasound doesn't have to heat and destroy tissue in a traditional sense to have a benefit. And this is a recent publication from the Japanese literature about using focused ultrasound therapy to treat epilepsy of the temporal lobe in a young adult. They weren't able to reach the target temperature, but yet the young lady was seizure-free and remains so to date. So where do we stand with this study? Well, by the way of summary, we've managed to treat 5 patients so far. 4 of those patients had hypothalamic hamartomas. And I would stress that this is just the beginning. This is sunrise, not sunset. And we're really not sure which way this is going to go. This is a safety and feasibility study. We need to finish the study. So we have incomplete data. We've only enrolled 5 patients so far, and we've not enrolled anybody younger than the age of 15. So as we try to move forward with this, we'd like to complete the trial with the help of our colleagues, and we're in the process of recruiting other centers to join us in the hope that we can complete this study and have the FDA's approval to then expand this to more centers and to more patients. I think also we're going to learn about what is adequate energy delivery by expanding this number of sites. I don't think traditional ablation is going to be necessary. I think energy delivery at sub-lethal thresholds may be effective. So there's a great deal yet to learn, but I'm hopeful that by completing this initial trial and then expanding it to what would be called a pivotal trial to prove the effectiveness, we can then bring this therapy to the wider medical community. I think neuromodulation, or using the energy levels at lower intensities that don't cause necrosis, will probably be the future. Again, I want to thank my co-investigators, Drs. Tierney and Miller, who were instrumental in developing the protocol. Dr. Nolan Altman, who's our chief of radiology and is an essential team member as we have done all of these treatments. He's been present for every single one. My partner, who now deceased, Sanjeev Bhatia, who was instrumental again in treating the first patient and initiating the trial. I'm proud to say that we have 2 very talented young colleagues, Dr. Mary Terry Fajardo, who's the epileptologist, who's taking care of the epilepsy patients, including the gelastic epilepsy and hamartoma patients with us, and my associate, Dr. Shali Wang, who's also part of the research group expanding focused ultrasound treatment. I'm happy to answer questions if I haven't run too far over time. I also want to thank the Insightec for their support, the Focused Ultrasound Foundation for supporting our patients and paying for the trial, and of course, the Hope for Hypothalamic Hamartoma for allowing me to speak. So with that, I'll say thank you very much, and I'll be happy to take questions if there's still time.
Yes, Dr. Ragheb, thank you so much for such a comprehensive review of a very technical subject. It was, I think the videos and the diagrams really helped to break that down for us. We have about 5 minutes, so I'm going to address a couple of the questions. And just to let people know that if you don't get your question answered today in this short time, we will be following up with Dr. Ragheb to make sure we get these answered, and we'll be sharing them via social media and via our website. So we will get those answered. There were a couple questions, Dr. Ragheb, one individual talking about having had a prior procedure and the seizures are under control, but obviously some of those comorbidities you talked about, the behavioral issues, some of the emotional, OCD, cognitive, mood, and eating disorders, is treatment for other comorbidities part of the clinical trial, or is it just seizure control?
So that's a really good question. I think, Lisa, what it reflects is our limited understanding of the complete spectrum of clinical manifestations from hypothalamic hamartoma, as well as the consequences of our treatment. So I think the person asking the question brings up a great clinical challenge. So we focus on the epilepsy because it's something we can record and measure. We, the clinicians, declare success because the seizures stop, but that's not always the same thing as what patients and families expect. And I think the challenge would be for us to better understand what's driving those other unpleasant symptoms, either from the hamartoma or as a consequence of our treatment. And honestly, if I'm not 100% sure that it's from residual hamartoma, I would be very reluctant to try to use ablation as a way to manage those unpleasant symptoms afterwards. And it's a simplistic strategy, but if I can't point to an obvious structural abnormality that isn't supposed to be there, then I'm left to conclude that the troubling persistent symptoms are from the disruption of the brain's normal function. And by damaging the brain further with ablation or trying to modulate those things, I think would be meddlesome and probably unsafe. Now, modulation has the potential to be able to change the brain's function in a reversible way. And I could foresee a trial in the future as we come to understand it better, where individuals like the person asking the question or their family member could be reversibly treated with focused ultrasound to see if it helps in a way that would last a few hours or a few days before we then went on to try to increase the energy to do it permanently. So stay tuned. I think there's a great deal to be learned about neuromodulation using lower energy levels to try to manage neurological symptoms and signs that we don't really understand.
Okay, I think we have time just for one more quick one. Understanding, and you've made it very clear that this is a clinical trial looking for safety and efficacy. How long do you—
Feasibility.
I'm sorry, feasibility. How long, if you are successful, do you see this being a potential treatment for both children and adults with HH?
Yeah, absolutely. I think that we're constrained by the current trial in our hospital's charter to patients under the age of 22. I know that other centers, as they come on board, will not be constrained as we are, and they may be willing to treat adults. The challenges of treating children are the geometry of the skull, and I didn't go into the technical details, the size, shape, and anatomy. I think that if there's an adult that has a lesion that could be treated, they certainly could be treated outside of this clinical trial in a unit that's up and functioning. That would take somebody that's comfortable with the device and the treatment. But we unfortunately are constrained by our charter as a children's hospital to treat children under the age of 22. But I think the potential is there, and I know there will be an adult trial. There are many centers across the country that treat adults with focused ultrasound, many, many more. We're the only active pediatric center in the United States currently.
Perfect. Thank you so much. That's our time with you today. We appreciate you spending this time, and we will definitely stay tuned.
Thank you, Lisa, for the opportunity. Thank you, Kathy, and thank you to the audience for their attention. Enjoy the
Great.
conference. Much success.
Thank you, Dr. Ragheb.